an autoimmune neurologic disorder. Myasthenia gravis, an autoimmune neurologic disorder. By Lexi Gray and Mary Kasich. Background: myasthenia gravis means grave muscle weakness. It is an autoimmune disease affecting the myoneural junction. About 60,000 people in the US have this disease. Women affected more frequently than men, at around 20 to 40 years of age. Men develop it later, at around 60 to 70 years of age. Symptoms: causes varying degrees of skeletal muscle weakness. Hallmark of the disease: muscle weakness increases during periods of activity and improves during rest. Areas that may be affected: eyes/eyelid movement, facial expression, chewing, talking, swallowing. Pathophysiology: normal communication between the nerve and muscle is interrupted at the neuromuscular junction, where nerve cells meet with the muscles they control. Normally, nerve endings release acetylcholine, which travels through the NMJ and binds to receptors, causing muscle contraction. In myasthenia gravis, these receptors are blocked or destroyed. Pathophysiology: autoimmune disease: the antibodies that attack or block the acetylcholine receptors are produced by the body's own immune system. Thymic hyperplasia or a thymic tumor is present in 80% of people with myasthenia gravis. Assessment: onset of the disorder may be sudden. Many times, symptoms are not immediately recognized as being related to myasthenia gravis. In most cases, weakness of the eye muscles is noticed first. Assessment: severe symptoms. Ptosis, drooping of one or both eyelids. Diplopia, blurred or double vision. Bulbar symptoms: weakness of muscles of the face and throat. Bland facial expression. Difficulty swallowing, increased risk of choking and aspiration. Dysarthria, impaired speech. Dysphonia, voice impairment. Weakness in arms, hands, legs, neck. Generalized weakness also affects intercostal muscles, resulting in decreasing vital capacity and respiratory failure. Confirming the diagnosis. Acetylcholinesterase inhibitor test confirms the diagnosis of myasthenia gravis. During this test, the breakdown of acetylcholine is stopped. As a result, acetylcholine is able to accumulate at the receptor sites. For this test, hydrophonium chloride is administered. Facial muscle weakness and ptosis will resolve about 30 seconds after the drug is administered, if the patient is positive for a myasthenia gravis diagnosis. This relief lasts only 5 minutes, so it is not considered a treatment. After the drug is administered, the patient's serum is then tested for acetylcholine receptor antibodies, which would also be consistent with the diagnosis. In some cases, patients with myasthenia gravis may have an enlarged thymus gland. Nursing diagnosis: number 1. Risk for aspiration RT, difficulty swallowing, weakness of bulbar muscles. Overall goal: no aspiration will occur. Interventions: give meals with anticholinesterase meds to inhibit breakdown of acetylcholine and increase its concentration at the NMJ. Raise the hob to semi-Fowler's position, which will ensure upper airway patency. Give food with a pudding-like consistency, which can be more easily swallowed. Nursing diagnosis: number 2. Deficient knowledge RT drug therapy, potential for crisis, myasthenic or cholinergic, and self-care management. Overall goal: patient will demonstrate knowledge of medication management, importance of rest, coping strategies, and prevention/management of complications. Interventions: teach patient about the actions of meds, and importance of regimen. The patient will verbalize the consequences delaying med intake, including S of myasthenic and cholinergic crisis. Teach strategies for patient to conserve their energy. The patient will develop coping strategies to avoid overexertion. If eyes cannot close properly, instruct patient to patch/tape eyes closed for short intervals to avoid corneal damage. Treatment of myasthenia gravis. Pharmacologic treatment. First-line med is pyridostrigmin bromide, mastinin, an anticholinesterase that inhibits the breakdown, thus improving skeletal muscle contraction. Side effects can include fasciculations, abdominal pain, diarrhea. Immunosuppressive therapy. Corticosteroids decrease the amount of antibody production. Cytotoxic meds, azathioprine, inhibits production of T and B cells, and effects may not be seen for 3 to 12 months. Hepatotoxicity is a risk of using cytotoxic meds. Some common medications exacerbate the symptoms of myasthenia gravis, including antibiotics, beta blockers, anti-seizure meds, Novocaine, morphine and quinine. Possible side effects of anticholinesterase meds. Central nervous system, respiratory/cardiovascular, skeletal muscles, irritability, bronchial relaxation, fasciculations, anxiety, increased bronchial secretions, spasms, insomnia, tachycardia, weakness, headache, hypotension, genitourinary disorder, gastrointestinal, frequency, syncope, abdominal cramps, urgency, seizures, nausea, vomiting and diarrhea, integumentary, coma, anorexia, rash, diaphoresis, increased salivation, flushing. Treatments: plasmapheresis, intravenous immune globulin. This procedure removes the patient's plasma and plasma components through a centrally placed catheter. Blood cells are separated from antibody-containing plasma. The blood cells are then mixed with plasma substitute and reinfused. Provides temporary treatment for severe symptoms. Intravenous immune globulin treats exacerbations of myasthenia gravis temporarily. This procedure does not work as quickly as plasmapheresis. These are treatments for myasthenia gravis, not cures. Treatments: surgical treatments. Thymectomy, surgical removal of the thymus gland, which may result in the production of antigen-specific immunosuppression, which results in clinical improvement. Results vary. Patient may have partial or complete remission, or no remission at all. Nursing considerations for the patient who received a thymectomy include monitoring respiratory function and mechanical ventilation. Myasthenia, or cholinergic crisis. Exacerbation of the disease process. Signs and symptoms include muscle/bulbar weakness. Causes for myasthenia crisis may include a respiratory infection, pregnancy, or medications. Primary management is focused on maintaining the airway. The nurse assesses respiratory rate, depth, breath sounds, and pulmonary function. Endotracheal intubation and mechanical ventilation may be necessary. Assess arterial blood gases, I and O, daily weight. Avoid sedatives and tranquilizers. Bradycardia and respiratory distress, emergency situations, are treated with atropine.